Assalamu alaikum wa rahmatullah. Good afternoon, everybody. Welcome to the 5th Arab Pediatric Congress. MashaAllah, I can see now the attendee, nearly 900. Definitely some of you who don't know me, allow me for 2 minutes to introduce myself. I'm Ahmed Hussein, consultant pediatrician, a member of the Royal College of Physicians in Ireland. I'm a managing director of a group of healthcare companies operating in Abu Dhabi. And I'm the chairman of Pediatric Club in Abu Dhabi. I just underline this Pediatric Club because part of my presentation will touch on this. I always believe that the best way to predict the future is to create it, especially after Corona. Let me update you on the Pediatric Club in general. I've been the chairman of Pediatric Club since long time, started in Saudi Arabia, and then in my home country in Alexandria, and then in UAE. In UAE, we started 2006. From 2006 until now, we've been progressing and getting more new members. The Pediatric Club format and agenda used to be regular meetings, you know, the formal presentations every 2 weeks. And then we used to have the workshops every quarter, every 3 months. And one of the outstanding was the Neonatal Resuscitation Program. We usually go annually for 1-day conference. And I just want to highlight on the milestones of Pediatric Club. We established 2 sub-clubs, one in 2009, which is the Perinatology Club with obstetricians and neonatologists, and the other in 2010, the Allergy Club. This was headed by Dr. Tamer Adam. He's in Canada now. We used to have certain programs like the Abu Dhabi Pediatric Practice. We run this program for 5 years, from 2009 until 2014. And also we have this one, the Arab Pediatric Congress. Started 2016. We only stopped it in 2020 because of the COVID, and then this is the 5th conference. I will just take you out outside the box from the regular formal presentations. Let me talk about something which you might be interested in. This is an introduction for our Department of Health, the regulator, which regulates the 3 Ps. I call them the 3 Ps: the patient, the provider, and the payer. Why I'm saying this? Because the Pediatric Club is now taking a new look. And I will take this opportunity to present my new thoughts and initiatives on this Pediatric Club. I hope you will like it. From now onward, I'll be targeting the private sector primarily, and some of the topics will be business oriented. I'm working on a YouTube for a medical business school, and what's more important now is the business platform. I'm trying to get it, hopefully it will be completed within the coming 3 to 6 months. And this platform will help all the colleagues who wants to establish new business or improve their referrals. The topic today is the COVID impact on pediatric practice. And the key aims and objectives will mainly fall into 3. This is to identify the areas of impact, and definitely everybody has witnessed the negative impact of COVID, but there are some positive impact. We will also discuss some of these effects, and then I'll explain how did we manage. Every Congress, I usually use some of my, I communicate with my colleagues and try to understand the situation, the current situation, and then get a theme. So this year, when I was thinking about the theme of Pediatric Congress, the Arab Pediatric Congress, and actually I wasn't sure what to do because we have already four conferences before, and I think we exhausted most of the themes. But based on what I said now, the new look of the Pediatric Club, I will still, I thought still to keep the pediatric subspecialties on top of the curve. Still, we need to talk to our pediatric subspecialty areas like the pediatric neurology, cardiology, surgery. But I also added some non-traditional presentations. I invited one of the quality specialists. He will talk about the mortality rates of COVID during COVID. The impact on the business. And I'm planning every conference will have one or two topics that will have a touch base on the private practice and the business. I have a group of healthcare companies, holding company, under which there are three companies who are operating in Abu Dhabi. I have a home care company and the medical center for pediatric rehab, and the standalone dialysis center in Al-Ain increased. So you have double impact. I'll go quickly through these two headings, but through discussing only two of my companies. This is the Pediatric Rehab Medical Center. Based on the double hit of the negative impact of COVID, we lost revenue. COVID, we lost revenue, and also the cost was increased. The revenue was lost because many patients have canceled their appointments. They were afraid to come to the center. Schools were closed because most of of our work coming through schools, and actually we ended up shutting the facility. So practically you had no revenue. And despite this, the cost has increased. The infection prevention control items were also more frequently purchased and at a higher cost because of the supply demand. More sterilization of the facility, and we have to conduct COVID tests for all the staff. In my home care company also, we have the same impact, loss of revenue and increased cost. We lost some patients because some of them, they just refrained from receiving. The nurses said no, they were panic. And Saha, in their attempt to fight COVID, they pulled many nurses from the private sector. So most of the home care companies, and I think other medical facilities, been suffering from a severe shortage of nurses because Saha gave them a very attractive offer. So we had some resignations. We could not replace them because the borders were locked. So again, you lose nurses, you cannot replace them, and there is inability to acquire new patients. It was a very strong impact negatively on the revenue, the income, and also the cost, the same as in the rehab. Even the transport, the Department of Traffic has released some memos that no more than 3 passengers in the vehicle. And this also cost us more money to rent new cars and hire new drivers. Although the impact was negative in most of the cases, but there was some light in the end of the tunnel where we had some positive impact. The online, for example, we never practiced before. We've started becoming more and more expert on Zoom, Microsoft Teams, WebEx. Webinars, we have many webinars during 2020, during the peak of the COVID, and this was free, of course, but it helped us in increasing the public awareness. So it was a sort of promotion for us. Working from home, although it has the pros and cons, but in certain designations, it was cost effective because the transport and this. And we ended up, I think, having some new visions, like some designations, we discovered that they should not be in-house. They can work from home. For example, licensing officer, why he or she should be in the facility, utilizing an office, and she can work from home because everything is online. So I believe even the certain designations will the way we look at it will change in the near future. I will not go more. I'll keep some slides for later in the discussion because I want to tell you how did we overcome this. And thank you very much for your attention. I hope you did not sleep yet. Thank you. The next speaker will be one of the very eminent physician and surgeon. Imagine we talk about Dr. Amin El-Gohari is one of the very senior colleagues. I met him in Abu Dhabi 2006. He was one of the early members in the pediatric club. He shared us his experience. He contributed a lot to the pediatric club. And I have to introduce him in full. But if this happens, we're not going to continue the webinar because it takes me 3-4 hours to introduce him. His CV, mashallah, is very rich. And all what I can tell you is that Dr. Amin carries behind vast experience, both in practice and academically. He's been appointed in many high-level academic positions and also practicing in Abu Dhabi for quite a long time. He is my trustee pediatric surgeon, and he's always sharing with us his experience. So Dr. Amin, please, Dr. Amin.
I honestly commend and congratulate Dr. Ahmed Hussein for his endeavors over the years. I have been part of all the previous meeting as well as the regular meeting that he was conducting and aiming at increasing the awareness of the common pediatric and pediatric surgical conditions. And definitely it's something that we are all appreciate, and he should be very proud of it. And I wish him all the best for the future endeavor. It's not because Ahmed is my friend. The good work speaks for itself. And Ahmed Hussein has done a remarkable job. Congratulations, Dr. Ahmed. I am a pediatric surgeon. The title of my presentation is Gastrointestinal Emergencies, and this is a vast subject. And before that, I would like to just mention quickly that I am a pediatric surgeon for the last 46 years. And this had spanned not only on a vast period of time, but also in different territorial areas in the world, in Egypt and in UK and in USA. And also I have traveled in all over the world. Apart of that, I'm also very proud that we have been indulged and practicing in charity organization under His Highness Marhum Sheikh Zayed Mission. And this was covering several countries, including Eritrea, South of Sudan, and recently Yemen. And this is a source of pleasure. I'm not saying that to flatter myself or the team that I'm part of it, but it is something that you feel satisfied that you are carrying the noble mission of practicing medicine. So without further ado, I'm going to talk about the vomiting of surgical significance. And this is the objective of my presentation. I'm going to discuss common causes of vomiting of surgical significance and discuss the clinical and radiological diagnosis of the condition that is highlighted by this vomiting. And the most important thing, and this is the aim, I know that there is, I think, 1 or 2 pediatric surgeons in the group, but the idea is to educate the general practitioner and pediatrician about the proper timing of referring the patient. I think most of the time, the first line who faces the pediatric surgical cases is not us. Usually we receive the referral from you. So I would like to give you what are the red line that you put in front of you, that the thing that cannot wait and the thing that warrant urgent attention. Now, why pediatric surgery? You know, pediatric surgery is the only specialty that is coined with age. Other specialties are coined with system, gastrointestinal, neurology, urology, orthopedic. But the only specialty that is associated and coined with age is pediatric surgery. And this is for the simple fact that the child cannot be considered as a small adult. That has been depicted in that picture. The child is not as a miniature adult. And this is why in the 50s, late 50s, Dennis Brown in USA, 1954, established the British Association of Pediatric Surgeons. And the slogan is that it is not to establish a monopoly, but to establish, to increase the standard, to set a standard for better practice. This was in the 1954. After that, there are many pediatric surgical associations that is spread all over the world. Not only that, but there are now subspecialties in pediatric urology, pediatric cardiology, and pediatric gastroenterology, and so forth and so on. So the child is not a miniature adult because there are major pathophysiological and anatomical differences that warrant the need for a specialized in that field. This is why there is a need for a specialized surgeon that covers, of course, the younger the baby, the more of course the need for specialization, especially the preterm babies. And now we're not talking about the preterm baby, we're talking about intrauterine surgery. There are certain conditions that if left until the birth of the baby, then it's too late. And it becomes spreading now in many centers, and also in the Emirates, we are embarking on that sort of practice. Now, these are the conditions that I'm going to highlight quickly. Of course, these conditions, every one of them will take hours, and it's a textbook of surgery, but I'm going to highlight the important clinical thing that of surgical interest to the pediatricians. I'm going to talk about inguinal hernias. I'm going to spend some time in intestinal malrotation, small bowel obstructions, Hirschsprung disease, imperforate anus, and esophageal atresia. Now, the orthodox teaching, when they teach the medical student, what are the cardiac symptoms of bowel obstructions? And of course, everybody knows that. This is abdominal colic or pain, abdominal distension, constipation. But the most important symptoms, please, and this is, if the end of this presentation, you remember this word, this is what I really need. The most important symptom is vomiting. You know, vomiting, bilious vomiting is the symptoms that does not require any other associated symptoms by itself is a red flag. Now, and why it's a red flag? Why the surgeons keep pressing this point that bilious vomiting is a dangerous condition? For the simple fact, the simple answer to that, it usually signifies an underlying bowel obstruction or bowel necrosis. So it's a red flag, bilious vomiting. And the most important dictum now, any baby, any child, any adult who vomits bile should be considered as having an underlying intestinal obstruction until proved otherwise. Now, please, please, everybody put that, as a red flag. Any baby who vomits bile should be considered as having intestinal obstruction until proved otherwise. I'm going to highlight on that area in the next 20 minutes. Even, now this, as I said, you don't need the other cardinal symptoms. Even if the child is passing normal stool, and even if the bowel is not distended, you don't need other symptoms to think that there is something serious that needs to be interfered with or looked at. You don't need anything else but vomiting. Now, because the worst of the worst is called something called mid-intestinal malrotation. It's a mid-gut malrotation. And what is the symptoms of mid-gut malrotation? The only symptoms is intermittent bilious vomiting. This is the only symptom. The child will have no distension, or the baby has no distension, is passing regular motions. The only symptom that every now and then you will have intermittent bilious vomiting. Now, what is malrotation? Now I'll give you a few minutes to, I don't expect you to know the anatomy in detail, but I'm going to explain it in simple terms. This is the normal rotation. This is the stomach, the duodenum cross the midline to the left. There is the DJ, that's the junction between the duodenum and jejunum. There is a white mesentery, and the cecum is in the right iliac fossa, and you know the rest of the anatomy. This is the normal rotation. What is malrotation? Now, this diagram shows or depicts the malrotation. Now, this is the stomach, and this is the duodenum. The stomach and the duodenum, and this is the bowel does not cross to the midline. The bowel does not cross. There is a very narrow mesentery, and the whole of the small bowel is on the right side. And in that narrow mesentery, there is a blood supply. And this blood supply is called superior mesenteric artery. You know, I don't know whether remember anatomy or not, but what does the superior mesenteric artery supplies? It supplies the whole of the small bowel and part of the large bowel up to the transverse colon, mid-transverse colon, which means that if this blood supply is interfered with, the whole bowel will be gangrenous. Now, in the malrotation, the cecum is not in the right iliac fossa. The cecum is in the right hypochondrium. And between the cecum and the second part of the duodenum, there is a band described by Ladd called Land band. Now, when the child is fed, this band stretch and cause intermittent obstruction that present with intermittent bilious vomiting, because this is the bile would be, because here is the duodenum where the common bile duct is opening. So when the child started to have a full stomach and the duodenum become distended, this band caused intermittent obstruction and presented with what? With intermittent bilious vomiting. So this is the sort of anatomy that there is a band here that extends from the cecum to the second part of the duodenum that cause intermittent obstruction. Now, what is the significance of that? If we do not recognize that condition early, this what happens, volvulus. And volvulus around that I explained to you before, around the superior mesenteric artery. And this means that the whole bowel will be gangrenous. This if you do not recognize the condition in the right time, you send the child, because what happens? The child comes with intermittent bilious vomiting, you give him some fluid and he improves. But this is the price of not recognizing the condition. So how can we diagnose intestinal malrotation? Number one is the symptoms, intermittent bilious vomiting. The only symptoms that warrant your investigation is intermittent bilious vomiting. Then you do what? This is the vomiting. This is the only symptom. Now, the second thing, it is investigation that makes the diagnosis more likely. Plain X-ray is pathognomonic. So the X-ray showed this is the pathognomonic. This is the pathognomonic of the malrotation, that the stomach and the duodenum is dilated. The bowel, you can see, is mainly on the right side. So you see that X-ray with history, the diagnosis is established. If you want to do some more investigation, you do some contrast examination. So intermittent bilious vomiting with this plain X-ray is the only parameter that we need to explore the child and correct the malrotation. Because if you don't, this what happened. And this appears in barium examination as corkscrew. This is the sort of twist that you can see, which by this time the bowel has been already affected and the blood supply has been interfered with. Now, if you have a very good radiologist who understands the anatomy, he can tell you that the arrangement between the superior mesenteric artery and superior mesenteric vein is in the opposite direction, because usually the vein on the right, the artery on the left. So this is also, if you have a good radiologist, he can tell you together with the clinical diagnosis and the plain X-ray examination. Now, this is what I'm like to highlight. Here, the Grammy winner, Maurice Gibb. Maurice Gibb died in 2003 because of bowel volvulus. The sad thing about that death, that he was in the history, in the back, if you look into the history of his life, he was admitted several times during the career of his infancy and the childhood to the hospital with intermittent bilious vomiting, and none during this time, nobody thought at the time to investigate his condition. So he lost his life because of our ignorance. This is the price we pay for not being aware of importance of bilious vomiting. This is what he died of. Now, I know that we have to stick to the basics. Ladies and gentlemen, abdominal examination. What are the boundaries of abdominal examination? The mid-chest to the mid-thigh. The mid-chest to the mid-thigh. No abdominal examination is ever complete without exposing the genitals. Please remember that. Not the courtesy of the baby that he is in cold weather. We don't want the child to be exposed. This is all silly excuses. No abdominal examination is ever complete without exposing the genitals. So because if we don't, this is the strangulated hernia. Now you just examine the abdomen and miss something that is life-threatening. So you have to expose the abdomen. You have to expose the genitals. And this is to diagnose a strangulated hernia. And you can see here, this is the child who showed gas in the scrotum, signified, it's sometimes it's a small knuckle that sometimes doesn't show. And this is here, you can see that this is a case of strangulated hernia with a bowel distension. This is my favorite question in the exam for the medical student. If we have a child that his hernia reaches to his knee joint, and one child, baby with knuckles just appear on a straining, which one you operate first? And the direct answer to that, it is not the size of the hernia that dictates the operation. It is the age of the patient. The younger the patient, especially preterm, the more urgent, because the incidence of strangulation in preterm babies and small babies is as high as 25%. So when the child comes to you in the clinic, please, preterm babies, small babies with hernia should be referred, and we operate on the next available list because of possibility of strangulation. Now, there is a condition that mimics strangulated hernia. This is tense hydrocele. Exactly looks like strangulated hernia. Tense swelling in the penoscrotal junction. How can I differentiate in my clinic between a tense hydrocele and strangulated hernia? Two things. If I can put my finger above the swelling, it cannot be a hernia, be hydrocele. If I put my finger above it, it should be a hydrocele. And the most important thing is transillumination. This is by put my finger here, and transillumination. Transillumination means that there is a fluid and not bowel. Now, I'll share with you a true story that happened to me many years ago when I was a resident in UK. That it highlights the importance of stick to the basic. Abdominal examination should include the genitals. This is the child, was 8 years of age, who admitted when I was on call. It was a cold night and he came with lower abdominal pain, suspected of acute appendicitis. Examination, mild tenderness. So I decided to admit the child under observation. And next morning, I was presenting the case to a group of senior physicians and surgeons. And history say that the child, 10 years of age, admitted last night, such and such. And I'm not convinced that it's acute appendicitis, so I admitted him under observation. And the question is, Amin, have we examined his genitals? No, this is really. I was struck by the question. I said, no, sir. Would you like to examine his genitals? Yes, sir. Torsion testis, gangrenous testis. So one of the differential diagnoses of abdominal pain is torsion testis, and one of the differential diagnoses also of abdominal pain is right-sided pneumonia. So this is the thing. Acute, ladies and gentlemen, remember two things. Lower abdominal pain can be associated with torsion testis, and the most important thing, that if you have acute radius scrotum, This is a fire brigade emergency. You have only 6 hours to save the testis. So don't refer, take the telephone, call the nearest hospital to you. Or if you know the surgeon by name, call him, I'm sending you a child with torsion test. And that when I received the call, I already put the theater on alert that we're going to take a child from the emergency to the operating theater. Now, there is one condition that we are proud that we have published. Also, we're learning from our mistakes. I'm just going 2 minutes to tell you about also a similar story that I faced when 35 years ago. I was a resident, actually not a resident, a house officer in one of the hospitals in UK, and it was Christmas Eve. And nobody would like to come to see, non-urgent cases in Christmas Eve. And despite the fact that I was a junior, but I had my practice in Egypt. I was a resident in pediatric surgery. I have seen hundreds of cases, thousands of cases. So my consultant was having a faith on me, and he realized that on that particular night, I will not call him unless there is something really I cannot manage. And this is a child, 9 years of age, with a severe abdominal colic. And there was a mass in the right iliac fossa. And when I did a barium at the time, it was diagnosed as intussusception. Now, intussusception in that age, it carried the possibility of having pathology of a tumor or something. And I explained to him that this is the condition, and he gave me the green light to go ahead and explore the child. And what a predicament I was when I opened the child. There was no intussusception and there is no tumor. It was a hard fecal mass at the terminal ileum and the cecum. And in the next morning, it was a disaster. He was bitterly criticized for allowing me to go ahead without coming and assess the case. It was one of the most embarrassing moments in my life. But then, of course, how can I answer that? It was clear that it was intussusception. Then he asked me to look for any similar case has been published at that time, and it was a unique case that has actually been later on, I published it 2 years back as a Gohari's phenomenon. Gohari's phenomena is the children who mimic intussusception. They come with severe abdominal colic, which in ultrasound, they give you an impression that intussusception. How would it differentiate between that conditions and the intussusception? Is the fact that there is a lot of stools. When you do the ultrasound, yeah, this is the target sign, but you can see also there is a stool there. And when you see a stool distal to the mass, it is Gohari's phenomenon. So this is the most important part of my talk. I'm just going now to speak about other things. I would like also, I mentioned that you have to exclude, you have to export the whole tummy to exclude groin pathology. And also, you remember that the fact that the baby passing stool does not exclude anal stenosis, because microscopic anus also the child will pass. So please examine the anus properly before labeling it as normal. Everybody knows now that most of the surgical conditions can be diagnosed antenatally. If any organ that is distended, whether the brain, hydrocephalus, the kidney, hydronephrosis, bowel obstruction, can easily be diagnosed. Spina bifida, everything with distension can be diagnosed antenatally. One of the things that we diagnose from the gastrointestinal point of view is the duodenal obstruction. And this is the appearance, the double cyst, not double bubble. There's a difference between double bubble and double cyst. There is no gas inside the gastrointestinal tract inside the womb. But when the child swallowed air, it becomes double bubble. This is double cyst, which it means if we diagnose that, we can plan surgery as soon as possible, because this is the site of bowel obstruction. And this, of course, this is the appearance antenatally, and this is the appearance postnatally. Now, I would like to highlight to you that all gastrointestinal obstructions, stenosis, or atresia occur during the 3rd trimester, except the duodenum. Duodenum happens during the 1st trimester of pregnancy and is usually associated with major anomalies, the chromosomal anomalies, renal anomalies, called Vater anomalies. Other obstruction, if you have distal obstruction, you have the vaginal atresia, and then distal more, you have the ileal atresia. And all of them require surgical management. Now, Another dictum. I did mention to you that any baby who vomits bowel should be considered as having style obstruction until proved otherwise. There is another dictum. Any full-term baby who failed to pass meconium within the first 24 hours should be considered as having Hirschsprung disease until proved otherwise. So don't take it for granted that you put a finger and he passed meconium, that this is normal. No, delayed passive meconium should be fully investigated to exclude, and we usually do a barium which shows this is collapsed segment, show the collapsed segment, and then you take a biopsy and this shows there's no ganglion cells, and you do the surgery. Now we do it either laparoscopic assisted or transanal. It becomes a simple procedure, relatively simple, with the new modality of transanal pull-through. So instead of having a full laparotomy, we just have 2 small holes and bring the whole thing from the bottom end. Now, this is the few 2 minutes or 3 minutes about the other things, the non-bilious vomiting of surgical significance. Now, when you speak about non-bilious vomiting, when we say a projectile vomiting, what projectile vomiting? Everybody tell you projectile vomiting is pyloric stenosis, and the other thing is going to speak about frozen baby. So this is the sort of see that the condition that sometimes you see it in the clinic, projectile non-bilious vomiting and equals pyloric stenosis. And how will you diagnose pyloric stenosis? Ladies and gentlemen, the diagnosis is clinical. You need to have good 5 minutes or 10 minutes of your time in the clinic and wait, give the child a shame feeding and look for this peristalsis here. Projectile vomiting, or the child who failed to thrive with peristalsis equal pyloric stenosis, you confirm that with ultrasound. And the treatment is not surgery. The treatment of pyloric stenosis is a medical emergency. The child should not be operated upon before correcting the hydration and electrolyte. You know, the mortality rate of pyloric stenosis in the 50s and 60s was very high because of the fact that severe hypokalemia can cause cardiac arrest. So please do not indulge. It's a medical emergency, not a surgical emergency. We have to treat hydration and correct the potassium before embarking on the procedure. So the most important thing, hydration and gastric electrolyte correction, then followed by surgery. Last slide. I hope that you have nurses in among the group. There is one condition should be diagnosed by nurses. Frothy baby means the baby cannot swallow saliva. And who diagnosed that? Who diagnosed that? The nurses. The nurses should attract the attention that the child is drooping saliva from the angle of the mouth, which means he cannot swallow, which means that there is an esophageal atresia that can be diagnosed by putting a catheter in from the mouth and measure the distance, and this is the diagnosis. Frothy baby equal esophageal atresia. So, summary, ladies and gentlemen, vomiting is a common symptom, yes, but remember that bilious vomiting by itself warrants full examination, clinical and radiological, and cannot be excluded without doing all the criteria that requires the medical and surgical attention. Now, abdominal examination is never complete without exposing the genitals. Any full-term baby who failed to pass meconium should be considered as having cell obstruction. And I would like, ladies and gentlemen, to remember that pyloric stenosis, to remind you that pyloric stenosis is not a surgical emergency, it's a medical emergency. And I hope, this is my email. I hope that I give you part of, I give you 46 years of my experience intravenously. I hope that you benefit from it. And thank you, Dr. Ahmed, for inviting me. I know that the question will be at the end of the second presentation. Thank you so much.
Thank you very much, Dr. Amin. We always enjoy your presentations, and every time you surprise us with some of the stories you have it in your early life, which is these stories are in fact I believe very beneficial for us general pediatricians and especially the junior colleagues. Okay, now we'll change the subject from the knife of the surgeon to the stethoscope and the EEG. Dr. Ahmed Yassin, a consultant pediatric neurology. He is a member of the Royal College of Pediatric Child Health from UK. And before this, he was also having some postgraduate qualifications from Vienna. He worked in Al Ain in Town Hospital for some time. And then he came to Abu Dhabi. We'll never allow him to go outside Abu Dhabi anymore. He's been in Abu Dhabi for some time. And he is one of my trustee pediatric neurologists whom I can easily, safely, and comfortably referring my patients. So Dr. Ahmed, please, I'll leave the floor for you. And again, I'm sure we will enjoy your presentation tonight. Thank you. Dr. Ahmed.
Shukran, Dr. Ahmed. Thank you very much. Bismillah ar-Rahman ar-Rahim. It is always a disadvantage to start after the Professor Amin Gohari, but this is my luck. I'm not so lucky with Dr. Ahmed Hussein. He's always putting me after the distinguished and very interesting topics. Anyhow, I will try not to let you sleep. I'm going to stick to the time, so I have to put my, it is 25 minutes, I believe. So starting now, Bismillah. My topic is going to be, which is imposed to me by Dr. Ahmed Hussein, impact of COVID-19 on children with autism. We did a study within this COVID-19 pandemic, and it is, I think it is very important because first, I think it is the only study done till now in UAE, and I'll just give you a background and objectives of this study. As you know, autism is one of the most common childhood onset neurodevelopmental disorders. The main objective of this study and research is to study the psychological impact of COVID-19 pandemic in Abu Dhabi due to the social emergency situation in children diagnosed with autism. We follow the DSM-5. Is the Diagnostic and Statistical Manual of Mental Disorders. It has now new criteria for autism, and it is the standard reference for healthcare providers. Okay, so what are these criteria for autism? First, you have to have persistent deficit in social communication. Usually these children have deficit in social, emotional, reciprocity. They have deficit in non-verbal communication, and they have deficit in developing, maintaining, and understanding relationships. Also, they have restricted repetitive patterns. They have stereotype patterns. They always do the same actions all the time, play the same with the same toy all the time, moving the wheels. They have highly restricted fixated interest, and they hyper or hypo. They have a hyperactivity to sensory input, and they have unusual interest in sensory aspects of the environment. These symptoms must be present in the early developmental period, that to say below 2 years of age. And these symptoms clinically impair the social and occupational or other important areas of function. And we have to rule out any intellectual disability or any genetic disorder. In the past, with DSM-4, there were diagnoses like autistic disorder, Asperger disorder, or PDD, pervasive developmental disorder, not otherwise specified. All of these now are not recognized. They are given only the diagnosis autism spectrum disorder. There is a condition, it's very important, which looks like autism, but it has the same, social communication problem, but it does not meet the criteria of autism. So this is called social or pragmatic communication disorder. So these children, they have inappropriate playing with toys. They don't have the inability to relate to others. They cry or laugh inappropriately. They are very hyperactive or sometimes just sitting without moving. They are oversensitive to sounds. They put their hands on their ears whenever there is high sound. They don't like high sounds. They have strange attachment to objects. They have poor speech, and they don't like change in routine. We have to see what is the severity of the autism, and this is depending on the level 1, 2, and 3, and this is usually diagnosed by the psychologist. I will just give you a video, so not be boring, about how to differentiate between a normal child and a child with autism with early signs. He's interacting with her, but see the other child here is not looking to the therapist, although he's playing with the phone, but he's not interacting with the therapist at all. So he's playing alone. He's not interacting with the therapist. Again, he's playing. He's not looking. He's not asking for any help. Although they wanted him to share, he's not interested. And the mother is trying to call him. She's calling him, and he's not answering her. And there is minimal eye contact. If you see here, the child has minimal eye contact. He's not looking to the mother. Although she's trying and giggling him, but although he's laughing, but there is no eye contact at all. So these are very red flags to that this child might have a problem. This is another child again. I don't think you can hear him, but the mother is calling him all the time, but he's not looking to her at all. Okay, so the COVID-19 pandemic has had an unprecedented impact on life around the world for many, many years. In the States, community transmission of COVID-19 was the first detected in February 2020. By mid-March, there were reported cases in all the 50 states, and the WHO also declared that COVID-19 was a global pandemic. This global pandemic led to a massive and immediate public health, as you know, campaign to reduce further spread. And this campaign encouraged distancing and behavior changes. So individuals with autism, they are the more vulnerable people, and they considered that they affected them more by this pandemic. We sampled about 100 individuals with autism from the patient database of Kids Heart Medical Center from June 20 to February 2021. Of course, as you know, the males are usually the more affected. The mean age was 4.6, and the age range was from 2.6 to 13 years. The only inclusion criterion was having been diagnosed with autism according to the SM5 criteria, and very important is to be done by a certified clinical child psychologist. And these patients, I have been following them every 6 weeks and have up to date medical records from their evaluation, The only exclusion criterion also was having a severe neurological disease. You have to rule out any neurological disease like cerebral palsy or so, and you have to rule out that these children have any genetic syndrome. We followed the child behavior checklist by the psychologist, which is a caregiver reported measure. We give it to the parents, and they answer some questions about the child behavior. And we put a T-score of 65 or above, which considered as clinically significant. This questionnaire has been widely reported for use in children with autism. Medical records of each autism participant were researched to retrieve similar evaluation measures conducted before the pandemic onset. And we designed a 10-point semantic differential scale. We assessed mood and irritability, sleep quality, feeding quality, weight, number of social initiations, anxiety, external and internal behaviors. So they have to answer on 10 points on semantic differential scale, which if you have a range from 1 to 4, this means that there is worse, less, or low behavior depending on the variable. And answers from 7 to 10, that means he's better or high depending on the variable. And answer from 5 to 6 were coded as no changes. I don't want to go to this statistical analysis, but anyhow, it was carried out on the results of the questionnaire and a descriptive synthesis of the main variables, the frequencies and means was performed. So our results shows that autism sample had a high rate of comorbidity. 76% had at least one psychiatric comorbid condition. And in this sample of 100 children, there were 43% had ADHD, 34 had mood disorders, 10 had tic disorders, 12 anxiety disorders, and 6 other comorbidities. When we checked the parents' results in their child during this pandemic period, 58 of the parents said that their child got more aggressive. They have tantrums and irritability. 22% said their child tics were increased. And 35 said that their child's communication skills deteriorated. And 42 to 31 of the parents reported that they have sleep and appetite changes respectively. So these researches have been done since the start of the epidemic or the pandemic. And for example, here from Amorim, they did a very good study where the caregivers of the children with autism also reported more anxiety during quarantine, both for themselves, for the family, and for the child compared to children without autism. There's another study also done by in Turkey, and also gave the same results that there's increased behavioral problems in children with autism since the pandemic started. White et al. Also surveyed caregivers of children with autism and found services and therapies for individuals with autism are disrupted. So as you know, putting masks will degrade the speech signal, and as you know, the decibel of level of attenuation ranges from 3 to 4 decibels for simple medical mask and close to 12 decibel for N95 mask. So the children, even if they hear you, they cannot understand what are you saying. This is for normal children. So also masks can obscure the social cues because they will not know what are you saying because there is no facial expressions. And as there is emergence of virtual and hybrid schools, this is also affected these children. Kindergarten and closure of schools also affected children usually, and more the patient with autism. And this is according to UNESCO. There's 1.6 billion people in 190 countries has so far been affected. That's to say 90% of the world's school-age children. There is also the impact of social interaction and language development due to distance measures. And this also affected children with autism. Even peer talk, as you know, children, they learn from each other, especially in kindergarten and schools. So this is affected also children with autism. There are many centers of autism were closed, and these children they missed their therapies, and there is delay in the treatment, and this has worsened the behavioral and cognitive outcomes of these children. The sedentary screen time of TV is increased in the children population, but also for children with autism. As you know, according to the WHO, children are not allowed to watch the TV up to the age of 1 year. So 0 minute, nothing in the screen, no TV for children, I'll repeat again, for children below the 1 year. And above 1 year, up to 2 years, it is allowed 60 minutes, but with the parent, with the child, engaging with him, not leaving the child alone on the TV. So this time was increased considerably during the pandemic. Children were sitting normal and children with autism for long periods. And as I mentioned earlier, delay of the therapy also affected the children. And unfortunately, many ABA therapy centers in Abu Dhabi do not include online programming. And even if they include this online programming, these children with autism, they have difficulty in the capacity to effectively engage in this virtual environment due to their attention challenges and the difficulty to understand what's happening. So in conclusion, our study portrays how individuals with autism were affected by the COVID-19 pandemic process shortly after the pandemic, and such an understanding is of key importance in planning psychiatric and psychosocial and education interventions in the future. So determining these aspects will enable development. We have to see how can we improve our implementation of clinical and psychological and educational services policies geared toward this population, which is global importance. As we know that autism incidence now and prevalence is 1 in 54 persons. It's very high. In every 54 children, you have a child with autism. So considering that individuals with autism exhibit similar difficulties at the face of this pandemic internationally, the investigations of autism populations through clinical and academic expertise is very important as an utmost priority during these difficult times. Thank you very much, and I share the same. I hope that somebody is awake, and thank you very much.
Thank you very much, Dr. Ahmed. As usual, we enjoyed your presentation, and now we already closed the first session. My presentation, Dr. Amin and Dr. Ahmed. We'll open the floor for discussion, questions and answers. I have here 4 questions now, 5, good. But before I open the floor to questions, Dr. Ahmed, I believe I have a comment. I believe not only the autistic children, this pandemic has also affected normal children. When schools have closed, and then you have the online program. Now, those who are suffering from the online are the parents, not the child. Children are very happy staying at home, not going to school. And we have observed as a general pediatrician that these children, they put on weight significantly because there is no activity, they eat a lot, they stay late, not as the usual days of the school. So I think this is again a general problem even for normal children. Okay, we'll open the floor now. I have question from, by the way, for the speakers, if you like to answer, please, this question for Dr. Amin. What are the symptoms of appendicitis in children aged 6 or 7 years?
Can you hear me?
Yes, we can.
You know, I don't know whether you noticed, but over the last 3 weeks, there has a sudden influx of patients with appendicitis. I don't know what is. I know there are seasonal variations of acute appendicitis, but you know, every day we have 1 case, and in the weekend we have 3 cases. So there is a sudden influx of acute appendicitis, and I cannot relate it directly to COVID, but there is something that I've been here in the Emirates for more than 36 years. This is the first time to see such increase of acute appendicitis in the children. And the last one is 2 years of age. In general, the younger the patients, the more the severe is the symptoms. because the omentum is in small babies is short and it does not seal the site of infection. It does not reach to the right iliac fossa. So if we have a child below the age of 5, it is 99% perforated. You know, the symptoms are not classic. By the time the parent brings the child to the either OT or to the emergency, the symptoms are far advanced. You know, what are the symptoms? The question that people are, of course, the child will have some pain. This is definitely, the pain is the salient feature of all acute appendicitis. Now, pain is number one. And of course, as I keep saying to my medical students, there is a language that's established between the hand of the surgeon and the abdomen. This hand tells you that there is something there, something surgical. So tenderness is as one thing, but guarding and rigidity are the sign that looking for if there is advanced infection or perforation. But there are cases where the child comes with abdominal pain and the appendix is retrocecal, hidden, or deep in the pelvis, where the clinical symptom does not, you know, dictate that there is appendicitis, in which case ultrasound in a good hand, so acute abdomen with ultrasound and tenderness equals acute appendicitis. And you mentioned the age of 6 to 7, this is the critical age. If you come earlier than that, the symptoms becomes vague and diagnosis becomes difficult. Now, we have putting a lot of stress on ultrasound, and if the symptoms are suggestive and ultrasound negative, we go for CT scan. But the CT scan has to be the last resort. I hope that answered your question.
Okay, thank you, Dr. Amin. There is a question for Dr. Ahmed. Is autism a genetic disease? What is the difference between high functioning autism and Asperger syndrome?
Yeah, thank you. Very good question. Yeah, actually, nobody knows. This is the answer, the short answer. Till now, as you know, we don't know the answer of autism. It is a mystery. We don't know. There are many, many hypotheses. One of them is that there is genetic susceptibility. These children have a genetic susceptibility, and these genes are mutated depending on the environment, on the bad environment, on the pollution. On the pollution means there is visual pollution, like children who are sitting in front of the TV from very early age, below the age of 1 year, and other pollutions, sound pollution and so on. So there's genetic susceptibility. The genes, I mean, there are many genes and mutation were diagnosed with children with autism. That's why we now usually refer children with autism for the geneticist to do the whole exome sequencing to see if there is any genetic involved or not. There are other theories, like something called cell danger response or integrated stress response. This is a new, it is not very new, it is about 2 or 3 years hypothesis that there is a metabolic disorder, and that's why they used a drug which is called, I don't know whether you know it, maybe Dr. Ahmed knows it, this is old like me, Suramin, which we used it in the past. I used it actually myself many, many years ago. I will not tell you how many years, for trypanosomiasis, for the sleeping sickness. It is an IV injection, and it was done by Professor Duveau, and he used it for a very small phase 1 and 2 for 10 children. And one of them is a 12-year-old child. From only one injection, intravenous injection of this drug, she was a nonverbal autistic child. She started to speak. They did not continue because of the pandemic of the COVID-19, but they are going to continue for phase 3 in this hopefully in this summer 2021. But again, we don't know what is behind the problem. Many hypotheses is behind it, but we don't know actually what is the cause of autism.
Okay, thank you very much. I think I will give the speakers the choice if they like to answer by writing or live.
Live, طبعا. I'd like to. Answering is will not be enough. I try to answer them because in case there is no time, but I would like, of course, to discuss it verbally.
Okay, if this is the case, we need to go quickly because there are many questions. Okay. The question for Dr. Ahmed again. Dr. Ahmed, what do you think about the use of artificial intelligence for autism during this pandemic?
What do you mean by artificial intelligence? Do you mean the virtual therapy and so on? I
don't know what does he mean, the person who asks, but AI maybe for certain devices using AI, artificial intelligence. Do you have any new devices using artificial intelligence in the treatment of autism?
I need the answer to be clarified. Can you skip it till he clarifies what is the question? Because if he is telling about visual, that I don't know if this is intelligence or not.
No, virtually already discussed in the presentation.
Yes.
Okay. So next question, again for Dr. Ahmed, MMR and autism relation. There is always this MMR is always
you said very short. You said very short answers, so there is no relation.
Yes, I think so. Okay. Yeah. There is another question. How can we feed picky eating child?
With autism or without autism?
I think we should relate it to.
If it is with autism, this is it is a sign, a symptom of these children. Usually they are picky eaters, so it is a integral part of their problems. So you have to try to start an ABA therapy, which ABA therapy is applied behavior analysis, which the main goal is to increase the communication problem in these children. These children have a communication disorder. They are not communicating. So before starting speech or occupational therapy, you have the ABA therapist tries to let them communicate with. They have their own tools. One of these things which they use also is positive enforcement and negative enforcement for these children for eating. What I tell always the mothers, children will not die if they are hungry. A hungry child will eat. If they don't believe that, come in Africa and see children who did not eat for 6 months. So, but mothers, they tell them, no, I waited for 2 hours and 3 hours, and again, so 2 or 3 hours not. So you have to manage this with some strict behavior, that this is the food that you have to eat. Put it in front of him. If he doesn't eat, you miss it for 1 or 2 or 3 times, and then he will be forced to eat. In addition to a therapy.
It's not only you, Dr. Ahmed. For pediatricians in their clinic, this always a question that my child is not eating. And when you take the child on the weighing scale, he is above the 50th percentile, active, running around. But the mothers always like their children to eat a lot. Okay. Dr. Amin, is Hirschsprung disease can be corrected and the child can live a normal life? Yes, I think yes.
This is what we hope to do. The Hirschsprung disease is a disease with wide spectrum. They can present sometimes with neonatal style obstruction. The child is born with abdominal extension, it did not pass meconium. And the thing that we do when the child, we just do a rectal exam. And the second phase is very important. The child will pass something called meconium plug. And everybody utters a sigh of relief. Alhamdulillah, He's fine. This is nothing. You know, the response to digital examination with patches of meconium plug is a Hirschsprung disease. You cannot say that this is the child had transient of constipation. This child has to be investigated by barium examination, by a rectal biopsy. Now, this is the first, the acute symptoms, but the other symptoms comes, of course, the delayed protracted constipation that is not responding to the normal measurement. Sometimes the abdominal distension, failure to thrive, these sort of things, that constipation that is not manageable by the normal condition warrant more investigation. Is it correctable? In good hand, you can have 85% near normal life. Of course, we cannot achieve, you know, some of the cases that did very well, but, you know, we have also to put the expectation with the family that the child will need sometimes regular dilations, will have special diet. The mother should be diligent about the fact that once he starts to be constipated, to contact the surgeon, so that sometimes they need to dilate his anus or put him on a special diet. But the long term, once the child started to be aware of the urge to defecate, and there is a regular healthy diet, they can achieve almost normal life.
Okay, thank you very much. There is a question for Dr. Amin again about the testicular torsion. How to diagnose testicular torsion in an infant less than 1 month of age?
Yeah, there are two types of that. I don't go to the surgical detail. There are two types of torsion. Neonatal torsion is a special condition called intravaginal, where the tunica vaginalis, the testis twist inside, and the child is born with it, and there is no single case in the medical literature that is not gangrenous. This is very sad. The child was born with tender, swollen hemiscrotum, and how would diagnose it as a torsion? By Doppler ultrasound. Doppler ultrasound will show there is no blood going into the testis, and most of the time, this has to be removed. The most important then is to fix the other testis, because the pathology is bilateral. So if you remove a gangrenous testis in a neonate in one side, you have to fix the other testis. Now, this is that very less. This is that we see, you know, case every 6 months or a year. But the common one, as I mentioned in my presentation, is the child who comes to you with acute scrotum. And the very sad thing that people diagnose that as acute epididymoorchitis. Please, there is nothing called like that. Please, you are killing your patient. There is nothing called epididymoorchitis in children. All red scrotum equal torsion tested until proved otherwise. Don't diagnose him and send the child home. You are killing him. Send him to the emergency. Tell them to the surgeon. Acute red scrotum equal torsion tested. Please.
Okay. This question is for Dr. Amin again. Is pyloric stenosis, once surgically managed, the child will have a normal digestive function?
Yeah, the simple answer is yes. Yes, the answer is yes. Yeah, it's really over the years the Ramstead, the only surgical procedure that has not been altered ever since it was invented by chance by Ramstead, who is the Prussian surgeon, is pyloromyotomy. The only procedure, and it was done by mistake. Now the story goes like that: Ramstead with a junior surgeon who was working under a very nasty professor who does not allow him to work. So once his professor left for a journey, the first pyloric stenosis came to him. He took the child immediately to the operating theater. He split. The operation was to split the muscle and suture it. It was hypokalemic, and the child had cardiac arrest before he could suture it. So he was resuscitated, and the child did very well. The thing is, he thinks, now, do I need to close it? No, I don't need. So it was an operation that was invented by mistake. This is pyloromyotomy by Ramstead. No, it's a simple procedure, very effective, and the baby will lead a normal life.
Another question for Dr. Amin again. What is the role and the regimen of antibiotics used in the management of appendicitis?
This is, people claim that early appendicitis can be managed by antibiotic, but it means that if we decide to treat early appendicitis with antibiotic, you have to admit the child to the hospital and be sure that the symptoms are not increasing. Now, the other thing is, once you diagnose acute appendicitis, you start antibiotic, but the simple thing, now we do laparoscopy. Laparoscopy is a simple procedure by which you just through small holes, you can remove the appendix out. Now, but if you are working in a situation where there is no facilities, yes, you can try antibiotic. With the modern facilities, yes, we cover the child with 24-hour antibiotic, but in the same time, book the child for laparoscopic. I think I can now, the last open appendectomy that I was done was 15 years ago. All the cases we are doing is laparoscopic. Even if they are perforated, if there is pus, alhamdulillah, with the modern technology, with the experience, all the cases can be done laparoscopic.
There's one question asked twice here. I think some people are having stress on this. Cordy and the hypospadias. They want to ask, yes, the diagnosis in a baby, can it go undetected?
Yeah, the hypospadias, you know, almost always associated with cordy. This is that when the orifice does not reach to the end, it usually associated with fibrous tract that is in the ventral side, which you call the penis to be curved. Now, sometimes clinically, when the child comes to the clinic, the curvature is not very clear. But how can we diagnose cordy? Of course, we have to treat the hypospadias by putting it in the normal position. But under GA, we need something called artificial erection, where you inject the saline and it will show if there is cordy or not. Because without correcting the cordy, the operation will not be complete. So of course, you can see sometimes the penis is obvious. There is a curve. But if it does not show that curve, the part of the procedure of repairing hypospadias is to test the angle during the operation by injecting saline into the corpora of the penis.
Okay. Now this is again, this is Dr. Ahmed. Autism like autoimmune disease. Is autism like autoimmune disease? I think Dr. Ahmed already mentioned that the cause is not very well known. There's some hypothesis for being genetic. Can you elaborate more, Dr. Ahmed? I don't think autoimmune, does it have a relation with autoimmune? You are on mute, Dr. Ahmed. You are on mute.
Is it okay now?
Yes.
Yeah. Again, there are many theories. One of them is autoimmune disease entering. But again, these all are theories. Nothing is concrete now. So we will wait with time and research and so on. This is for short answer.
Okay. To Dr. Ahmed again, can autism in toddlers be reversed with therapy or early intervention?
Well, very good question. With my experience for the last 20 and 21 years with children with autism, whenever you intervene early and diagnose early, I have seen toddlers and children below the age of 2 years. Within few months, you cannot believe that this is the same child. I remember one child who was coming to me even from Dubai, and I told the mother, no, you brought the other, maybe this is a twin, because she brought the child after, I think, 2 or 3 months. It's a very different child, communicating, saying high five and putting his hands, and different for that child who brought. So my message is, as Dr. Ahmed Hussein said, and Dr. Professor Amin, the early referral is very important. Early referral, they say whenever you diagnose early, you have to suspect. I have many children who went to many, I'm not incriminating anybody, but many colleagues, they tell them, wait and see. This wait and see process or wait and see phenomenon is very bad. There is no wait and see again. You don't wait and see. This is maybe 30 years ago. This early intervention is very important. Whenever any child who has language delay, even from the age of 1.5 years, is not saying any word, please refer him to the specialist, to the pediatric neurologist or the psychologist to assess him. Assessment is not a big deal. If there is everything is okay, that's it. So early assessment is very important. And if you start the therapy, and the most important for me is the prevention is better than treatment. What is prevention for me? I give them a paper, instructions. The first thing for me, there is no TV, no electronics for any child below the age of 2 years. And then especially now with this pandemic, you have to engage with your child. Fathers, they have to engage their child. They have children. Many, especially fathers, they tell me that I awake in the morning, the child is asleep. When I came in the evening late, the child is asleep. So I see him only on Friday. So, and the mother sometimes is also working and putting the child only with the nanny, and the nanny is putting the child in front of the TV, and the child spends, I have seen children at the age of 4 and 5 months put on the TV for hours. And this is actually very bad. So prevention is very important. Yes, if you, the answer to the question, yes. If you intervene early, especially below 2 years of age, I guarantee you with a child within few months will be okay.
There is a question. Thank you, Dr. Ahmed. There is a question here in the same context. In fact, you already answered it, but to satisfy the person who asked, how to get rid of this screen timing for children? As Dr. Ahmed said clearly, the family should be committed, involved with the child, and spend some time with him. But Dr. Ahmed, let me ask you myself, because this is not only for autistic children. In general, we would like to minimize the screen time for all children at all ages. Now, do you have any, from your own experience, do you have any tactic to teach parents, especially in this room now, we might have some mothers, either nurses or doctors. So if you, with your gray hair and the vast experience behind, do you have some tactics to teach us how mothers can get the child involved away from the TV, away from the screen?
Yeah, very, very, very important question, Dr. Ahmed. Actually, the only way.
I received a question on my mobile. I think the doctor knows me, but there is no name. He texts me on the WhatsApp with one question. He said that in the presentation, I already mentioned about, talked about the negative impact of COVID on our business, and how the revenue or the income was lost, how the cost was increased, and we were helpless. Then he asked me, what did you do? And I think that's a very good question. I didn't want to bother you with some of the growth initiatives or the business initiatives, but in fact, basically, before every year, in the last quarter of a year, we prepare budget for the next year. And this budget will be for the revenue and the cost. Now, we didn't know about COVID. So in September or October 2019, we prepared the budget for 2020. Now, with the beginning of 2020, we were hit with the COVID, and all what I explained in my presentation was negatively influencing our business. So to overcome this, we should not just sit quiet and cry. I think I'm proud of my team. We did good job. We have very good achievement during the COVID in 2020, to the extent that despite that COVID, we achieved our budget, which we set in 2019. Some companies have been struggling, so we were able to buy these companies. This is an opportunity, and this all with the pros and cons of the COVID itself. We were able to buy 2 companies. We infused some technology to cut down the cost on the manpower. the workforce, because the workforce was less than expected. So we infused some technology. We called international bodies for partnership and to tie up. And in fact, we found that some of the international bodies were interested to enter the UAE. So we were able to represent one in the UAE. So this will also has helped us in our business. And we started using the RPA. RPA is the robot processing automation. The robot process automation, this is the new technology which will let you perform with very low manpower and effective, efficient operation. So I think we did well. And this is to answer my colleague who answered. Yes, Dr. Ahmed, back. Welcome back.
I'm sorry. I'm sorry.
Yes.
Yeah. Can you repeat the question? I forgot it.
Yes, the question was based on your vast experience and the gray hair you have. We need some tactic you teach us because all of us are suffering now from kids, the screen time for kids.
Yeah, you have to work hard with your children. I remember my father, rahimahullah, maybe he was a very active sportman, and he played with us tennis. He is the only one person, maybe in Sudan, who had 2 grass courts of lawn tennis in our home. We learned how to swim, long swimmers. That's one of the activities. We go to this now. This they call taekwondo and fighting. I don't know, remember the names of these. Kung fu and whatever. So you have to engage your child, and this needs effort from yourself. It needs sacrifice. You have to go to the parks with this small child every day. I advise the children, especially whenever you have signs of autism, every day the child should not be locked inside. You have to go with him at least 1 hour outside. Even if you go on the street, it's better than staying at home. So there are many things you can do it. You can tell stories to their children. You can buy books and read with them the stories. Many things can be done, but you have to engage your child. Nobody is going to do that for your child. You have to spend quality time with your child. This is the answer.
Yes, thank you very much. I think this is not only for the screen time, but it will also increase the bond between the kids and their family, because this time you can find in many houses, every child has got his own room, his own laptop or iPad, and there is everybody is living in isolation, which is having a very negative impact on the social life. Okay, I think we're about to close this session. I should say that I received many comments, more than 30 or 40 comments on the speakers and the presentation. I really extend my great appreciation to Dr. Amin and Dr. Ahmed, because all the comments are positive, and really thank you very much for joining us. We'll go for now a break. Then we'll allow you the time to pray Maghrib, and then we'll meet inshallah after Maghrib, say 7 p.m. المغرب يمكن 6:45, 6:46. So we'll give you the time to have your coffee and pray, and then we'll meet again at 7 o'clock. The next session will start at 7:05. Thank you very much, and we'll see you in 15 minutes. Thank you.